it's wonderful to see so many of you all here to learn about breathing and sleep problems and neuromuscular disorders that might be affecting you or that you worry might be affecting you. And many of you may be having difficulty in finding the appropriate tests or finding a good doctor and finding out what treatment is necessary if you need treatment and getting the appropriate treatment. So to present the facts and clarify some of the misunderstanding about this topic, we are fortunate to be able to take advantage of the expertise of some expert neuromuscular pulmonologists and respiratory therapists who have come to San Diego to attend the annual meeting of the American College of Chest Physicians, which starts tomorrow. So we appreciate their donation of their time and energy for this event. They will be aided by a local pulmonologist, even though he has a British accent. Anyway, he's local. And of course, representatives from the ventilatory equipment manufacturers and distributors in the area, and the other local nonprofit health organizations. So with all of them and with you as consumers, we should have a wonderful afternoon that will integrate all your different perspectives about this subject. So again, thank you all for coming. So let's begin with what happens to your breathing muscles, what causes respiratory muscle and nerve damage, and what are the symptoms of respiratory muscle weakness. And to answer these questions, we have Dr. Geoffrey Sheean. He is director of the Neuromuscular Service at the University of California, San Diego Medical Center and clinical professor of neurosciences at UCSD's School of Medicine. He helped to establish the UCSD ALS Center, and in his neuromuscular clinic, he sees and treats many varieties of neuromuscular disorders, such as post-polio and muscular dystrophy, myasthenia gravis, and on and on and on, almost. He is very active in publishing papers. He conducts clinical trials. He serves on advisory boards, and he's an invited speaker, as you will see, at many other medical conferences. So we're glad he's able to be with us today. So welcome, Dr. Sheean. Sheean.
Thank you. Well, good afternoon, everyone. Can you hear me? And most importantly, can you understand me? Let's hope. That might become clear as we go along. It really is a pleasure to be here this afternoon at this remarkable symposium. I'm impressed by how quickly it was all thrown together and how efficiently as well. So my thanks also to the organizing committee and the sponsors and to the Salk Institute. Well, I'm here ready to lay the groundwork for what will come later, which are specific lectures on the subject of breathing mechanics and the like, and how it's measured. But what I'm going to do is talk about the particular neuromuscular conditions that lead ultimately to this problem of difficulty breathing. And they have many things in common, which is mostly weakness of the breathing apparatus, but comes about in many different ways and might progress in many different ways as well. So it's important to understand that, and the way that neurologists do this is generally by dividing things up by the structures that are important in the production of neurological functions such as breathing. So firstly, there's a breathing center in the brain. I'm not going to talk very much about that. That might come up later on. But that's very important for driving the whole process of breathing. And there is an area in the lower part of the brain stem which is devoted to that. I will get this right in a moment. Just about here and there. And from there, nerves go down, not directly as it seems to be here, to the muscles, but there's another area going down to the parts of the spinal cord that supply nerves to the diaphragm. And really, most of the neuromuscular problems that occur and that affect breathing are due to weakness of the diaphragm. Other muscles of the breathing apparatus can be affected as well, but the diaphragm is key. So I have a little video here of, I hope, the mechanics of respiration. Looks like that one didn't make it on. Anyway, I was told to cut 10 minutes, so this would be a good thing. So, the diaphragm essentially is a very large muscle. I think most people realize, where it is. It's sort of underneath the rib cage, like that. And when it contracts, it flattens, and that pushes the abdomen contents away and helps inflate the chest. Essentially, produces most of the expansion of the chest through breathing. So very important muscle indeed, and that's why we are going to start talking about just a little bit above where the diaphragm nerves come from, between the area where the breathing apparatus is, up here somewhere, and down around here, spinal cord injuries can occur, and they interrupt the drive from that pulmonary center down to where the nerves for the diaphragm originate. And a very high spinal cord lesion, such as shown here, turns you into a quadriplegic who is dependent upon a ventilator, because those respiratory centers can no longer drive the phrenic nerves, which are those which originate in the high cord and go to the diaphragm. So we mustn't leave that out as a cause, but it's not a neuromuscular cause as such. To understand the mechanics of breathing, you need to understand the concept of the motor unit. And this essentially is a nerve, an anterior horn cell in the spinal cord, a nerve that goes out to the muscle and connects to the muscle by a neuromuscular junction. So we have several structures: nerve cell, nerve axon, connections between the nerve and the muscle itself. So about 4 things where problems can arise. We'll take them one by one. The anterior horn cell is the site of attack of polio, and destruction of that leads to the death of the nerve fiber that goes out to the muscle. So this is essentially the head of the nerve, and without it, the axon, which is the nerve fiber part, running out from there, for example, will die. And if there is no nerve supply to parts of the muscle, then those muscle fibers will not be able to contract, and so there will be weakness and fatigue of the muscle. And the anterior horn cell is the site of attack of polio, causing weakness and wasting in other muscles, the old iron lungs that used to be very common in earlier times, and the consequences, which is thinning of the muscles and deformity of the bones as a result. There are other causes of diseases that affect the anterior horn cell as well, genetic ones, for example. There's something called spinal muscular atrophy, which will be seen over at the Muscular Dystrophy Association clinic. It's a genetic disorder which generally affects children, but can also affect some teenagers and young adults as well, with a late onset of a problem. There is progressive degeneration of these anterior horn cells, and the same effect occurs, but much more slowly. In polio, the effect is rather quick. The attack on the anterior horn cells is very rapid, and so there is a rapid loss of function. Here, we're talking about a degenerative disorder which develops very slowly. And then there's Lou Gehrig's disease, which is an acquired degeneration of the anterior horn cells, usually affects people in mid to late life, sometimes younger. And, for example, Lou Gehrig was 36 when he developed it. And it's not just confined to the anterior horn cells that go to the diaphragm. It could be any of them to go into the arms and legs, and even those similar fibers that go to speech and swallowing muscles. But breathing is certainly a major part of it. Other famous people, Stephen Hawking, who quite possibly has the most benign form of that condition, having had it for about 40 years, and then David Niven, who died fairly quickly as a result of this. So this is somewhat different to the other two. It's degenerative, but it's rapidly degenerative compared with the spinal muscular atrophies, but it's nowhere near as rapid in its destruction as poliomyelitis. And of course, those nerve fibers which were affected earlier by poliomyelitis, of course, may degenerate later on through mechanisms which we don't quite understand, and that could affect breathing if it didn't in the original attack. The nerves that I've been talking about, which go from the spinal cord directly to the diaphragm, are called the phrenic nerves, and they run in fairly, very close to the midline, pass through the neck and down past the heart. So they can be affected with surgery done on the chest and on the heart. And some people find, unfortunately, that after they have such surgeries, one half or even both halves of their diaphragm, there's one for the right and one for the left, they may not work. They can also, these nerves, be attacked by the immune system and be knocked out together or separately. And this ends up causing severe difficulty breathing, as you might imagine. So moving on from the nerve part, there's the nerve and muscle connection, which is called the neuromuscular junction. And that is shown just here. Now, one nerve fiber doesn't just go to one muscle fiber. It usually goes to a number of them, which can range between 5 and 1,000 or so. Here it shows that the nerve is branching out to one muscle fiber there, another one there, and another one there. And so this one anterior horn cell has one nerve fiber which splits at the end and goes to a number of different muscle fibers, and that's called the motor unit. And the more fine the control that's required, such as in the eyeball muscles, the fewer muscle fibers there are, so you've got the best control. Where control is not important, say in chewing, you have a number of them. But that means that one nerve, one anterior horn cell, if lost, loses 1,000 muscle fibers, can result in a dramatic reduction in strength. This is, I think we might have time for this one. This is a video showing how that neuromuscular junction works. So we might roll that one. So nerve impulses are coming down the nerve fiber, and this is the junction here, and it's split out into a number of little terminals connecting to an area known as the end plate. And underneath that area, which I hope will show up shortly, here it is here. This is what this looks like. So this is the muscle fiber, and this is the end of the nerve. And this end of the nerve is going to release a number of little things. Once the nerve impulse reaches it, it's going to release these little vesicles with like little bubbles full of a chemical called acetylcholine, which goes between the nerve and this area over here on the muscle fiber where there's a receptor for it. And when it attaches a couple of these to the receptor, that opens up and starts an electrical chain of activity which causes the muscle fiber to contract. So rather than a normal wire which is attached to something, the electrical impulse comes and directly touches on whatever the contact is. With nerves, it happens rather differently. There's a chemical released, and things can go wrong at this neuromuscular junction here. For example, in a condition called myasthenia gravis. In that, there are antibodies which attack this side of the connection, and so while these things might be released, there isn't any place for them to attach on the other side, and so the impulse can't transmit from the nerve to the muscle, so the muscle fiber effectively doesn't work. And if that happens to lots and lots of muscle fibers, then that would cause weakness of the diaphragm. Now, not only is there weakness, but there's also a rapid fatigue. Sometimes these connections file for a while, and then they just give up. So it's not just straightforward weakness. They may fatigue very, very quickly as well. Fortunately, this is not very destructive. In other words, if you can get rid of these antibodies, everything goes back to normal. So this is rather different from the other conditions in where the damage is essentially irreversible and very little compensation available, especially when the anterior horn cell is affected. So this is a more positive condition to have. It can be difficult to treat in some cases, but isn't ultimately very destructive, so therefore is potentially curable. And it produces not only weakness of the diaphragm, but weakness of the eyelid and weakness of eye muscles as well. And I think this is where we'll save about 8.5 minutes if we don't show this video, if anyone wants to see it. It's from 1935. It's amazing, from a county hospital in London, showing, we won't roll it, I don't think, because we don't have time, but it shows a remarkable response to therapy in myasthenia gravis. And the breathing muscles can be just as responsive, I should say, to the treatment. So of the many causes of neuromuscular weakness of the diaphragm and the breathing apparatus, this is quite probably the best one to have. So I think we'll just move on. So muscle, finally, we've gone through the anterior horn cell, the nerve fiber itself, the connection between the nerve and the muscle, and now we're actually on to the muscle. And muscle fibers, if you cut them in cross-section, look like that, but they actually run the length of the muscle from one end to the other. And muscle can be damaged by a number of different things. Inflammation is the most common of the acquired problems. In other words, something that you weren't necessarily born with or genetic. Is some type of inflammation, usually an immune system attack on the muscles, and they destroy individual muscle fibers. So this is a slightly different effect in the muscle. Previously, if you destroyed an anterior horn cell or a nerve, you knocked out a whole swathe of muscle fibers that were part of that motor unit. Here, they get picked off one by one. So it produces a somewhat different appearance on the muscle biopsy. You can see that there are big areas here where there aren't any of those muscle fibers that there should have been. For example, back here, it's jam-packed full of muscle fibers. Here, there are areas where there aren't. There's some shrunken little ones here. These dark areas represent inflammatory cells which have come in and are actually attacking these muscle fibers and destroying them one at a time. Now, it can also be a genetically determined deterioration of muscle fibers, such as muscular dystrophy. Most of those are, well, they're by definition genetically determined degenerations of muscle fibers. And Duchenne muscular dystrophy is perhaps one of the most commonly recognized, mostly affects boys almost exclusively, and affects the muscles in the, see those very thin, but they get these very large looking calves, which unfortunately are not strong, but that's characteristic of that, and that's due to a buildup of fat in that area. So it looks like they should be able to walk on their toes, but they aren't actually able to. They're not strong at all. So this is a genetically acquired one, which generally means that they develop fairly slowly. So they're like the spinal muscular atrophy of the anterior horn cell in that it comes on in childhood and progresses relatively slowly. The inflammation is more like polio, where it comes on rather quickly and can do a lot of damage to the muscle fibers in a very short period of time. Fortunately, most of those inflammations are actually due to the immune system attacking muscle fibers in autoimmune disease, and that makes them amenable to treatment. And Duchenne muscular dystrophy is due to a lack of something called dystrophin, which is necessary to keep these muscle fibers intact. So, any part of this motor unit, the anterior horn cell in the spinal cord, the nerve going from the spinal cord to the muscle, the connection between the nerve and the muscle tissue itself can be responsible for weakness of muscles, including weakness of the diaphragm and other muscles of the breathing apparatus. It could be genetic, muscular dystrophy, inflammatory, poliomyelitis, or muscle inflammation, traumatic in the case of the nerves, immune system attack just about anywhere, and some degeneration of which we are not very clear on the mechanisms, and that includes the mechanisms of post-polio. We don't know why the anterior horn cells seem to, in later life, start to run out of steam. Lots of theories about it, but it's not entirely clear. And it all results in weakness of the diaphragm, and that leads to essentially two symptoms: shortness of breath with exertion, or even sometimes not with exertion, and a difficulty breathing when lying flat. And that might be spoken of a little bit later as well. So I won't go into that too much. It results in insufficient ventilation and these symptoms here. And the differences between them essentially depend upon the rapidity in which they come on, whether they're progressive, whether there's a late deterioration, and whether there's a substantial reversibility possible, as in the case of myasthenia gravis, where you can inject something and get breathing back to normal, at least temporarily. But there are oral medications, and that's about the only one of these that is amenable to that kind of treatment. So I hope we've got about 10 minutes left for any questions and maybe some answers too. Yes, sir, in the front row. I think there's a microphone coming, so everyone will be able to hear.
I have PLS, and I have had atrophy of the left side of the shoulder, and I suffered atrophy after I had a midfoot fusion before I was diagnosed with PLS on the lower part of my left leg. I currently, they've opened, the VA has opened it up for ALS, and their definition of PLS is the rarest form of ALS.
Right, there are types of motor neurone disease if you want to group them, and Lou Gehrig's is one particular type called ALS, but there are variants, and PLS is one of those, which you're saying you have. Does it affect your breathing?
I have had, I'm on a breathing machine at night. I have sleep apnea.
Mm-hmm.
And also I've had, approximately 2 years ago, I had some problems with swallowing, and general practitioner gave me a pill and said that, you know, I had, problems with stomach, and I was later went to specialists diagnosed with aortal and paraesophageal hernias.
Yes, well, there are some, exactly, because reflux of gastric contents can aggravate breathing problems, and sleep apnea, I didn't really talk about that because I think that might come up later on as well, but sometimes sleep apnea can be induced by muscle weakness related to some of these neuromuscular conditions. I was focusing on the diaphragm quite a lot because that's the main powerhouse of breathing, but obviously you have to have open airways, and that requires a certain amount of muscle tone in some cases, which might be reduced in some of these conditions too.
I had the type of condition where I had, or the doctors operated with the, without opening me up. I can't remember what it's called.
Laparoscopic surgery of some sort.
Laparoscopic, but that came apart,
Mm-hmm.
and I ended up with an ulcer, bleeding ulcer, in hospital and
Well, there can be
sometime.
It's another, for everyone else in the audience, surgery under these conditions, general surgery particularly, is rather more complicated if you have a weakness of the breathing apparatus as well. And you have to be rather, the anesthesiologists have to be rather more careful than usual, and you're more vulnerable to other complications from surgery too. Are there any other questions before I have to hand over to the next speaker?
Oh, I had a cardiac arrest in '07, and I never had breathing difficulties. And after I was in the hospital and came home, I get winded real easy, walking up and down steps and everything. And I was wondering if it, and you were saying something about a nerve running down to the phrenic nerves.
Yes.
That can be damaged through a heart attack or surgeries or whatever. And I was wondering, how would you know if that happened?
Well, actually, I'm not sure. That might come up a little bit later, but there's an easy way to tell. By the doctor listening to your chest, he might hear air moving in and out of one lung and not the other, or maybe there's not much air moving in either of them. And then if an X-ray is done with you taking in a deep breath, they might find that one of the diaphragms doesn't actually go down at all, or maybe they both don't go down. So, it may require some special X-ray technique to show whether there is movement of the diaphragm or not. But it's certainly one of the causes of shortness of breath after operations that are done on the chest is sometimes temporary, but sometimes permanent injury to the phrenic nerve, and one or either side of the diaphragm might become affected. So it's very easily checked on. You're welcome. Some others?
Chest-crushing automobile accident causes phrenic nerve damage.
Yes, the phrenic nerves can be damaged, particularly if there's blunt trauma to the chest, if there is trauma to the neck. So they run down the side of the spine, sort of make a little detour around the heart, and then end up on the diaphragm. So if there's anything coming, if there's anything coming right on you like that, or up here in the neck, and of course, the area of the spinal cord, if there's a spinal cord injury where those phrenic nerves start from, if that's affected, or even if it's just above that, there will be breathing problems.
What are the symptoms that your diaphragm might not be working properly?
Well, sometimes the first symptom is that you might not be able to lie flat and breathe comfortably. I think symptoms are going to be addressed in a bit more detail in the next talk, but shortness of breath with exertion and inability to lie flat are two of the commonest of those. But I'll leave that. I don't want to steal anyone's thunder. There'll be more talk of that later, shortly, in fact.
Who's the best medical group to make that diagnostics on your anterior
CSD.
horn cell? I'm sorry?
UCSD, the best medical group, did you say?
Yeah.
Absolutely right. Sorry. The best...
Types of medical doctors that are going to be able to make that diagnosis, would it be cardiopulmonary or respiratory or?
Well, sometimes it goes through a number of different specialties because it's not clear why somebody's short of breath. It could be for lung reasons rather than for breathing muscle reasons, or it could be for cardiac reasons. And ultimately, these things tend to be excluded, and then eventually, most people end up either with a pulmonologist or with a neurologist, neuromuscular, if it's clear that the difficulty breathing is actually due to underventilation, lack of expansion of the chest, for weakness of somewhere in that motor unit that we've talked about. So it could be in either. Yes, I think we have time for one more, I believe. Oh, there's one down the front. Okay. Oh, and one right there.
Can we blame the anterior horn cells for the urinary symptoms in polio survivors too?
Most likely, yes. So the question is, in post-polio syndrome, in the late deterioration, if there is progressive weakness of the breathing muscles, it is most likely due to the progressive loss of the remaining anterior horn cells that survived the original attack, but seem to no longer be able to keep up. Now, you don't want to make the assumption just because you've got post-polio syndrome and you're getting short of breath that it's all due to that. I mean, there are many other possible causes, and so it might require cardiac, pulmonary, and maybe neurological evaluation to try and work out exactly why you are becoming short of breath. So don't let it just go assumed that it is due to that. But that is the mechanism. I think the final one.
You mentioned about the surgical procedure that the neuromuscular patient has to be careful of with regards to anesthesiologist.
Yes.
And then when you have a need to have a surgery done, you want to have a consultation with a pulmonologist and anesthesiologist and so forth. But what type of medication should we avoid, to avoid having long recovery
Right.
with the patients with ALS or that type of things?
Most of the time, if somebody who has a weakness of their diaphragm for a neuromuscular reason, and especially if it's actually due to a problem with connection between the nerve and the muscle, the anesthesiologist will try to avoid using paralytic agents. In other words, they usually paralyze you to make it easier to ventilate and for the surgeons to operate, but they might try to avoid that because the effect could be very prolonged. Afterwards, they would normally expect that to wear off very quickly, but that might not be the case. But that's also potentially the case for people who have neuromuscular weakness of their breathing for other reasons, not just because of that myasthenia. So it's worthwhile everyone being cautious in that situation. Well, I think I must resign the podium because it's time, and I'll hand back to our MC. Thank you very much.